Hi and welcome to Lessons from the Grand Rounds. In this short video, we are going to discuss a very interesting case, and I'm going to give around 10-11 points from the EPMT manual about the topic. So let's go with the clinical case. So this is a 12-year-old boy during my transplant posting. So he is a case of aplastic anemia, and he is taken up for mud transplant, which is a matched unrelated donor transplant at an age of 12 years. So the conditioning regimen was fludarabine cyclophosphamide ATG with the GVHD prophylaxis regimen of cyclosporine, methotrexate, and abatacept. So abatacept he received approximately 4 doses by day 28, and then monthly he was receiving abatacept as part of GVHD prophylaxis. So he was doing fine till day plus 80, where there was only few admissions for some viral URI and dysuria and urinary tract infections, simple urinary tract infections, which we had ruled out initially for BK virus cystitis. So this patient comes to the casualty with complaints of fever with a temperature maximum of around 102 Fahrenheit and also bilateral neck swelling. So he had, on examination, he had bulky cervical lymphadenopathy with the largest left cervical lymph node, posterior cervical lymph node being around 3 to 4 centimeter, and persistent fever spike. No other localization. Examination looks fine. No other organomegaly. The basic investigations look fine. So an EBV DNA PCR is sent, and the copies are 3 lakh. So with the overall background of a benign disease with a mud transplant presenting as fever, lymphadenopathy with the EBV DNA viremia, the probable diagnosis as of now is a post-transplant lymphoproliferative disorder, which is the interesting topic which we are going to discuss today. So, we perform a PET for the patient where we have primarily supradiaphragmatic lymph nodes in the left cervical, in the bilateral cervical region, no other uptake, and the biopsy is being performed. So the excisional lymph node biopsy shows atypical lymphoid cells with on IHC but positive for CD20, 30, Iberish was positive, and the Ki67 is 70%. The pathologist has labeled the biopsy findings as a case of polymorphic lymphoproliferative disorder related to immunodeficiency of dysregulation of immune system. So this is a case of post-transplant lymphoproliferative disorder, which now, as per WHO 2022, is being named as immunodeficiency associated lymphoproliferative disorder. So we are going to discuss few approximately 10 important points. The reference is from the beautiful manual of EBMT for transplant. So PTLD, or the immunodeficiency associated lymphoproliferative disorders, are a result of uncontrolled neoplastic proliferation of the lymphoid or the plasmacytic cells uh, um, in the context of extrinsic immunosuppression. So here we gave the patient cyclosporine, we gave methotrexate, but then he was on frequent doses of abatacept, which kept the patient immunosuppressed. So PTLD is divided into a probable PTLD and a proven PTLD. So when before the biopsy, everything was probable PTLD with fever, lymphadenopathy, and EBV DNA viremia. When we confirmed it on the biopsy, the case turned from the probable um, PTLD to proven PTLD. And there are multiple types histologically, 6 types. So as I mentioned, it was a polymorphic type of PTLD. So there are 6 different types. So few atypical PTLDs can be EBV negative, few of them can be T lineage, and few of them can be composite B and T lineage. So the pathogenesis is that under extrinsic immunosuppression, there is proliferation of the EBV, and there is EBV induced transformation of the B cells in the setting where there is impaired anti-EBV cellular immunity. And this is in cases where we have GVHD prophylaxis, which removes the T cells from the graft, which increases the risk of PTLD. So the clinical manifestations include primarily fever and lymphadenopathy. The median time to present is the first 6 months. So some of the presentations can be after 5 years. So those cases are being represented as malignant lymphoma separately and not PTLD. So the incidence is more in mismatched mud transplant, that is mismatched unrelated donors, followed by the matched unrelated donors, followed by haploidentical transplant, and also transplants where there is T cell depletion, which which promotes more immunosuppression as compared to the other cases. And it is seen that the post-transplant cyclophosphamide use uh, actually lowers the risk of PTLD. So what we do here for diagnosis is we first did the EBV DNA PCR, second thing was a PET scan, third thing was the biopsy. So these are the most important points. The other thing is what are the risk factors for PTLD. So risk factors for PTLD is essentially proportional to the degree of T cell depletion or the impairment, and this is the principal risk factor. So all the protocols which use T cell depletion, even if the family match donor, and EBV serology mismatch, positive EBV in the donor whereas negative in the recipient, and the risk. The high risk groups include the mud transplant, which is matched unrelated donor or mismatched unrelated donor, or matched family donors with at least one risk factor, which we mentioned before. So we have diagnosed this case. So how do we treat this? So treatment includes three major factors. So the first thing is use of rituximab. So we give rituximab 375 mg per meter square weekly for 4 weeks at least. And the second thing is a reduction of the immunosuppression. So we cut down the immunosuppression, we taper out the immunosuppression. And the third thing is adaptive immunity in the form of uh, uh, lymphocytes directed at the EBV from the donor, or extrinsic adaptive immunity. So when we treat the patient with all the three measures, we see significant improvement in clinical as well as the EBV DNA viremia. So this was all about post-transplant lymphoproliferative disorders. If you have any questions, you are welcome to comment on the page, and we'll be discussing more about this topic with all the references whichever I can give. Okay, thank you.